Yes, thank you. Grant Woodruff, presenting on the also a malperfusion syndrome with an acute type A aortic dissection. Acute type A aortic dissections are a life-threatening condition, usually mandating urgent or emergent surgical intervention. A subset of patients present with malperfusion syndromes, and visceral malperfusion carry significantly higher morbidity and mortality. Again, the standard approach being open proximal aortic repair to prevent rupture, tamponade, and death, although management may become more nuanced with malperfusion syndromes. In these cases, there's ongoing debate whether an aorta first strategy for patients versus those with end-organ ischemia may benefit from maybe an initial endovascular intervention and stabilization prior to their definitive surgical repair. This is a 70-year-old male presenting with an acute type A aortic dissection. He presented with acute chest pain, back pain, abdominal pain, and left lower extremity weakness. By presentation to the hospital, he had motor and sensory deficits to his left lower extremity. He had abdominal pain as well, and a significant lactic acidosis. CTA was obtained, showed a type A aortic dissection with extension distally to the left common femoral artery. In the left external iliac artery, the false lumen was thrombosed, and there was significant true lumen compression resulting in a left lower extremity limb ischemia. In the visceral segment, you can see that the true lumen is severely compressed. The false lumen causes a dynamic obstruction into the SMA. Discussions were had with CT surgery. He was deemed a poor operative candidate and asked if we had any interventional options available for revascularization. We said yes. So he was taken to the operating room in our hybrid operative suite. Bilateral femoral access was obtained. True lumen access was gained in the right common femoral artery, and false lumen access was obtained in the left. This was confirmed with IVUS. From there, we were able to use a crossing catheter in the descending aorta to snare through and through wire access. I don't know if you can see it up here. There's a wire from the true into false lumen. Here we created a fenestration by pulling down on the through and through access, and under IVUS guidance, we were able to watch the intima become a common channel. Here, as you can see, we started to pull down. We see the intima kind of bunching and then releasing into a common channel. This helps to depressurize the system and create equalization of the true and false lumen. In order to promote further true lumen gain, thoracic stent graft was deployed into the common channel into our true lumen, and here we can see significant true luminal gain and resolution of our visceral malperfusion. The left external iliac artery was then treated with a self-expanding bare metal stent and 4-compartment fasciotomy performed. Postoperatively, the patient's abdominal symptoms eventually resolved as lactic acidosis resolved and distal pulses returned. A couple days after surgery, he did develop an ileus, so a repeat CT imaging was obtained. Here we can see the true lumen has significantly increased in size compared to preoperatively, and again, his lactic acid and malperfusion has resolved. So visceral and peripheral malperfusions complicating type A aortic dissections represents one of the more challenging scenarios in aortic surgery. Although urgent central repair is considered gold standard, severe end-organ ischemia and those patients that may be poor surgical candidates for immediate open repair, endovascular first strategies are an option. This case really highlights the importance of an individualized management strategy and the role of hybrid endovascular approaches for therapeutic options for this high-risk surgical population. Thank you.